Good afternoon, everybody. My name is Erin Colvin. I am a member of the PAC3 Education and Outreach Committee, and wanted to thank everybody for attending our second webinar in the Inpatient Acute Care Education Series. PAC3 is collaborating with Hart University to host a series of educational webinars for the inpatient provider. PAC3 is committed to providing educational opportunities targeting the inpatient arena. The series will begin with basic knowledge of each topic, and we plan to build upon each topic with additional webinars as the series evolves. So for some housekeeping items you'll see in the webinar chat, we have talked about these. I'll be on mute for the duration of the webinar. If you have any questions, please add them to the Q&A. If time allows at the end, we'll read the questions of the presenters so they may answer. If we're unable to answer live, then we'll send an email follow-up with the answers. So on to today's webinar. Today's webinar is entitled Introduction to Cardiac Catheterization for the Inpatient Provider. This features Dr. Bryan Goldstein and Jamie Bloch from the UPMC Children's Hospital of Pittsburgh. Dr. Goldstein is the director of our Cardiac Catheterization Lab and has been with us in Pittsburgh for a little over 6 months. Prior to joining us in Pittsburgh, Dr. Goldstein was an interventional cardiologist at Cincinnati Children's Hospital and Medical Center. Jamie Bloch is a nurse practitioner who has worked within our Heart Institute within the Cardiac Cath Lab for over 15 years. She is an integral part of the Cath Lab team as well as a division of Pediatric Cardiology. So I'm excited to welcome them and enjoy the webinar.
Thank you to everybody joining us this afternoon, and thank you to PAC3 and Hart University for allowing us to present our talk on cardiac catheterization to your group.
Good afternoon. We're really excited to be here together as a team from Pittsburgh and look forward to talking about cardiac catheterization with the entire group from PAC3 and Hart University. So thank you for the opportunity to join the group.
Today we'll be presenting Introduction to Cardiac Catheterization for the Bedside Provider. I have no disclosures, and Dr. Goldstein holds consultant roles with various device companies and also has an advisory board role for PICA Labs. Our objectives today are reviewing the history and basic principles of cardiac catheterization, giving a primer on cardiac interventions, common indications for catheterization, reviewing pre-procedural planning, interpretation of findings and interventions, reviewing post-procedural management, complications, and providing a summary.
Thanks, Jamie. All right, it's a tag team effort this afternoon. So the history of cardiac catheterization dates back pretty far. In 1711, Hale used a long copper tube which was inserted into the carotid artery and jugular vein of horses, and a pressure was measured based upon the displacement of water. In 1844, Bernard utilized a thermometer placement in the carotid artery and jugular vein of horses to measure temperature in the ventricles, and this was adapted shortly thereafter to measure pressure directly. And Röntgen in 1895 developed the first X-ray, which heralded the opportunity for both still and live X-ray in the future. Adolf Fick in 1870, working in Germany, developed really the principles of physiologic interpretation and understanding in cardiac catheterization in utilizing oxygen to understand cardiac flow. And this was suggested as a principle as if a train were pulling boxcars, and those boxcars were full of wood chips being produced at a factory here at a given rate and utilized by the city or the town at the same rate. So at a steady state, production and utilization of the wood chips were the same. If one knew the number of boxcars on the train and the percentage full each boxcar was, then one could back solve for a flow or cardiac output. And that is what heralded use of the term Fick principle in the modern era. Werner Forsman in 1929, working at Charité Hospital in Berlin, placed a urinary catheter in the antecubital vein after a cut down that he performed on himself. He then advanced the urinary catheter, took an x-ray and advanced the urinary catheter all the way into the right atrium. His fate was rather interesting in that he was excluded from the field of cardiology and felt to be a lunatic for having done this, became a urologist and ultimately a country doctor, and later was awarded the Nobel Prize for Medicine for really the first cardiac catheterization procedure. So in discussing basic principles of catheterization, we'll review pressures, cardiac output, concept of intracardiac shunt, measure of vascular resistance, manipulation of physiology and other caveats, brief review of angiography, and then interventions that are relevant to our field of pediatric cardiology. The measurement of intracardiac pressure is performed typically through the use of fluid-filled catheters and a pressure transducer. The transducer converts membrane displacement from the fluid-filled catheter to an electrical signal, which is then displayed digitally and can be manipulated digitally. The transducer is leveled to the mid-right atrium, and there's a number of sources of error, including air, clot, leak, or fling artifact within the system. This is an example pressure recording on the left of the screen of the right atrium, and on the right of the screen of a pulmonary capillary wedge position simultaneously with left ventricular waveform. And one can see aligned with the P wave is the A wave within the right atrium. And shortly after the T wave electrically is the V wave mechanically. So there's an electrical mechanical association, which is not instant, but occurs. There's also a mean that is present on the waveform. And so one of the first things that becomes notable in interpreting these waveforms is the very fact that a human must interpret them, that this does not spit out a number of 5 or 10 or 100, but an interpretation of an actual waveform. And here in the left ventricle and pulmonary capillary wedge, one can determine the end diastolic pressure, which is typically where the wedge A wave and the late diastolic filling occurs on the ventricular waveform. Normal intracardiac pressures are displayed in this diagram, with typical right atrial pressures being low and a mean of 1 to 5. Right ventricular systolic pressures also being quite a bit lower than the systemic pressure, typically about 20–25% of the systemic pressure, but 15 to 25 systolic over an end diastolic pressure of 5 to 8. The pulmonary artery pressure mean is typically in the teens to about 20, with a mean pulmonary pressure of 25 or higher, meeting criteria for pulmonary hypertension. The left ventricle typically has an end diastolic pressure that is less than or equal to 12, quite a bit lower in small patients, and they're single digits of years. And the left atrial pressure is typically a mean pressure of 5 to 10 millimeters of mercury. Reviewing the Fick principle, this is the gold standard in the case of intracardiac shunts and requires measured and sometimes assumed values. Thermodilution is the gold standard in the absence of intracardiac shunt or right-sided valvular regurgitation lesions, and can be challenging in smaller children and infants to obtain. The Fick principle requires the cardinal oxygen saturations, which is a mixed venous saturation. In pediatric cardiology, that's most routinely the SVC in the presence of intracardiac shunt, or the pulmonary artery in the absence of an intracardiac shunt. The aorta, pulmonary vein, and pulmonary artery saturations are either necessary or an assumed value is necessary. Oxygen consumption can be measured when feasible and a machine is available, otherwise can be assumed. Hemoglobin can be measured, and the constant for oxygen and hemoglobin can be used. And here's the equation on the bottom right of the screen. Thermodilution may be measured with a Swan-Ganz or thermodilution catheter, most typically advanced from the internal jugular vein, but can be advanced from the femoral vein as well. And here an injection port is present proximally to the pulmonary valve, typically in the right atrium or right ventricle, and a thermistor or distal port is present distally, which measures temperature. And based upon the temperature curve following an injection of a known quantity and known temperature saline, the computer will back calculate the cardiac output. In the presence of intracardiac shunt, flows are derived from the Fick principle. These are based on, quote, saturation runs in the cath lab, whereby a number of saturations to fill out the cardinal saturations are obtained using catheters. This is typically reported as QP to QS, or the QP-QS ratio. A QP-QS ratio greater than 1 has more pulmonary blood flow than systemic blood flow, and therefore is reflective of a net left to right intracardiac shunt. A QP-QS less than 1, where systemic blood flow is greater than pulmonary blood flow, is indicative of a net right to left intracardiac shunt. And of course, a QP-QS ratio equal to 1 is consistent with no net shunt. As a physiologic measure, it's important to recognize that shunt fraction, or QP-QS, is impacted by perturbations in physiology. As vascular resistance is altered, therefore the shunt may be altered too. So this is really a dynamic measure and not necessarily a fixed measure. Vascular resistance is calculated utilizing Ohm's law, or V equals IR, solving for resistance, whereby V is a change in pressure, I is flow or cardiac output, and R is resistance. This is reported as Wood's units, or index Wood's units, as Wood's units times meters squared. Normal resistance in the systemic vascular bed, or SVR, is between 9 and 30 indexed Wood's units. Normal pulmonary vascular resistance, or PVR, is between 1 and 3 indexed Wood's units. And a normal RP to RS, or pulmonary to systemic vascular resistance ratio, is less than 0.1. Here is an example of a patient who has atrial and ventricular level shunting. This patient had elevated right ventricular and pulmonary artery pressure by echocardiography, and there was clinical concern that they weren't in heart failure and therefore may have elevated pulmonary vascular resistance and be high risk for surgical correction of the septal defects. They underwent cardiac catheterization. During the catheterization, pulmonary pressure was measured and was noted to be elevated with a mean pulmonary pressure of 25, meeting criteria for the diagnosis of pulmonary artery hypertension. However, the SVC saturation, or mixed venous saturation, was 65%, and the pulmonary artery saturation was 86%. This yielded a QP to QS ratio of 3 to 1. Utilizing the elevated QP, the pulmonary vascular resistance calculated at 1.2 index Wood's units, which is normal. Therefore, this patient was allowed to proceed to cardiac surgical correction of the septal defects without concern for high-risk status. In the cath lab, we can also manipulate cardiac physiology. We can utilize pharmacologic therapies, whether it be oxygen, inhaled nitric oxide, IV pulmonary vasodilators, including titration of patients who are on existing pulmonary vasodilator therapy. We can use vasoactive medications for systemic vascular manipulation, including epinephrine, norepinephrine, and others. And we can manipulate chronotropy. We can increase the heart rate. Fluid challenge may be performed whereby rapid volume expansion is delivered of IV saline, most typically, to evaluate for change in compliance. Exercise and stress may be performed, as is the patient in the panel to the right. This is a patient with Fontan physiology who's undergoing cycle ergometry with jugular venous access and a wedge catheter advanced into the pulmonary artery to obtain mixed venous saturations, pulmonary artery or Fontan pressure, as well as pulmonary venous wedge, or pulmonary arterial capillary wedge, or left atrial surrogate during cycle ergometry. We can also perform pacing, either the introduction of pacing or modification of existing pacing, to understand the impact of these changes on hemodynamics. Here's an example of a patient who underwent baseline testing as well as rapid volume loading, rapid volume expansion. It's a 25-year-old male with hypoplastic left heart syndrome who underwent stage palliation to Fontan completion. He has increasing symptomatology. At baseline, his evaluation was not particularly revealing, with a mean Fontan pressure of 12, which is typical, and an end-diastolic pressure of 12, which is also typical. However, after a fluid challenge, this patient's Fontan pressure was 20, and end-diastolic pressure was 22, consistent with evidence of diastolic dysfunction, which is most likely an important contributing factor to this patient's symptomatology. Caveats to steady state understanding of physiologic assessment in the cath lab. First, hemodynamic assessment really demands steady state physiology. Cardiac output, shunt fraction, vascular resistance, pressure gradients are all significantly impacted by baseline state. Data acquired in the cath lab is not necessarily a predictor of past or future clinical performance unless it's acquired in the same physiologic state. Frequently in the cath lab, we utilize general anesthesia and positive pressure ventilation, use paralysis and general anesthesia, and these are not how patients live their lives. So it must be understood that assessment in the cath lab in a particular state is not necessarily predictive of a patient early before or after that catheterization procedure. A brief introduction to angiography. We perform fluoroscopy and angiography in most pediatric cath labs using a biplane system. The C-arm that is directed straight over the patient's chest is the AP or A plane, whereas the lateral or B plane projection is 90 degrees to this. And these camera angles may be manipulated from straight AP and lateral, which are often frequently helpful to evaluate the right ventricle and pulmonary arteries, to RAO and LAO projections, which may be better to look at the left ventricle, and many other angles. Here's an example of rotational angiography with subsequent 3D reconstruction. This is a video from Darren Berman, who's an interventional cardiologist now at Nationwide Children's, demonstrating a patient who undergoes rapid pacing, breath holding, and then a rotational angiogram acquired with the frontal C-arm in the catheterization laboratory. And utilizing this technique, a rotational angiogram is developed. This rotational angiogram can then be post-processed into 3D reconstructions, which are able to tease out very specific angles to evaluate, in this example, distal conduit and proximal pulmonary artery obstruction. CT-like evaluation utilizing cath lab technology. Here's an example of the cath lab at Cincinnati Children's Hospital, demonstrating a lot of technology and equipment has come to the cath lab to facilitate complex procedures in 2020. Here's another example showing the control room, again, with a lot of technology, cameras, recording information, and ultimately ability to manipulate reconstructions in real time. This is an example of the cath lab from Children's Hospital of Philadelphia, demonstrating the relationship of the biplane cath lab to a cardiac MRI unit, allowing for patients to go back and forth between the cath lab and MR to obtain physiologic and anatomic data in the two environments in real time. So just a brief primer on interventional terminology and a bit of history of intervention. In 1966, Bill Rashkin performed the first Rashkin procedure at the Children's Hospital of Philadelphia, which was a balloon atrial septostomy. This procedure had not been performed in the catheter laboratory before this, but instead had been performed operatively. And this Rashkin procedure, or BAS, was a dynamic jerking of the balloon atrial septostomy catheter for treatment of a restricted atrial septum, most typically in detransposition of the great arteries. Alternatives to the Rashkin would be static balloon or stent atrial septoplasty, which may be utilized in patients with hypoplastic left heart syndrome and intact or restrictive atrial septum, for example. Here's a picture of the balloon atrial septostomy being performed with a cartoon on the left and imaging on the right. You'll notice a transthoracic echocardiography over the chest, as well as the use of fluoroscopy for that procedure. A number of other interventional terms are displayed here. First, valvuloplasty, such as balloon aortic valvuloplasty. This is balloon dilation of a stenotic heart valve. Angioplasty, for example, right pulmonary artery dilation. This is balloon dilation of a typically stenotic blood vessel. Stent angioplasty is performance of balloon angioplasty with a balloon expandable endovascular stent mounted on that balloon. And therefore, when the balloon is deflated, the stent remains deployed and is able to exert radial force on the lesion. Covered stent angioplasty is the same, but utilizing a stent that is covered with a material, most typically EPTFE or Gore-Tex, that blocks any flow through the side cells of the stent. Here's an example on the left of balloon pulmonary valvuloplasty. You'll notice a narrowing in that balloon, which is the valve itself, and that narrowing then goes away with further dilation. The mild narrowing that remains on the balloon at the end of the dilation is actually the pulmonary valve annulus. So in this case, the pulmonary valve balloon is slightly oversized compared to the annulus itself. In contrast, in aortic valve angioplasty, in aortic valvuloplasty on the right, the balloon dilation is performed and waste is eliminated. There is no waste at this point because the aortic balloon is purposely undersized from the annulus so as to not create significant aortic valve tear and therefore limit the amount of aortic insufficiency that occurs as a consequence of the balloon dilation. Here's a series of still frames of a patient with recurrent coarctation of the aorta after surgical coarctation correction with really severe stenosis and a 50 millimeter pressure gradient under general anesthesia. The coarctation lesion is balloon dilated, and following the balloon dilation, there is significant improvement in the degree of coarctation with complete resolution of the pressure gradient, although angiographically there's still a mild narrowing that remains. Here's an example of stent angioplasty, also in a patient with coarctation and significant collateralization. Here, the use of a covered stent, depicted on the bottom right, is placed. That covered stent is EPTFE lined to reduce the risk of aortic aneurysm, dissection, or rupture. And after the relief of coarctation, there's nice angiographic flow through the lesion without significant obstruction remaining. Other terminology to discuss today: vascular or collateral embolization, typically AP or venous collateral embolization, is the occlusion of flow in a blood vessel with use of a variety of means, including polyvinyl alcohol particles or microparticles, coils, vascular plugs, and other techniques. We perform device closure in the heart, such as ASD device closure. We also do VSD and PDA device closure. Here we place a device, oftentimes but not always purpose-built for the lesion, to close an intracardiac or vascular shunt. Transcatheter valve implantation, in pediatrics most commonly transcatheter pulmonary valve replacement, consists of placement of a balloon expandable stent mounted by a prosthetic valve in the heart, most commonly in the pulmonary position. In the soon future, there will be self-expanding stent technology to use in large dilated outflow tracts, such as in late after repair of tetralogy flow. Here's an example of a patient with single ventricle physiology. The angiogram is performed in the left subclavian artery, and one sees lots of AP or arterial pulmonary systemic pulmonary collateral connections between the arterial tree and the pulmonary artery tree, with subsequent arterial dye entering both the pulmonary artery and pulmonary venous phases. One can use a variety of means to occlude these collaterals. In this case, particles were chosen. Particles are not radiographically evident, so one does not see the work performed, but after the work is performed, angiography reveals no more flow into the pulmonary arterial or pulmonary venous trees. Here's an angiogram of a patient with a PDA. This PDA can be crossed and a PDA closure device placed, here still attached to the delivery cable. And after a complete deployment and release of the device halts all flow through the PDA, and now angiography fills the aorta and the stump of the PDA, but flow does not enter the pulmonary arteries through the device. A number of devices used for PDA closure over the years are depicted in the panels to the right. ASD closure may also be performed. Here, an ASD device is being released from its delivery cable within the heart, and fluoroscopy of the device in AP and lateral projections demonstrates its position within the heart and within the atrial septum. Here's an example of a patient with a right ventricle to pulmonary artery conduit. That conduit has been in place for decades and has heavy calcification with severe stenosis and insufficiency present. A series of interventions are performed, including the placement of covered stents, followed by dilation of those covered stents and placement of bare metal stents that are stronger, followed by placement of a transcatheter pulmonary valve within the stented right ventricular outflow tract conduit. And ultimately, angiography demonstrates the lack of insufficiency and the lack of stenosis within this rehabilitated right ventricular pulmonary conduit via minimally invasive transcatheter means. A couple of other interventions worth mentioning: neonatal palliations are increasingly performed in the cath lab, such as PDA stent or RVOT stents. These are transcatheter approaches to palliation of a symptomatic neonate with cyanotic congenital heart disease who either has ductal dependent pulmonary blood flow or requires some form of augmentation of pulmonary blood flow for an initial palliation, or would undergo primary neonatal repair if that were a possibility, such as in tetralogy. Thrombectomy is also worth discussing and goes along with recanalization of occluded vessels, which often occurs in pediatric patients or may occur in pediatric patients, typically following long intensive care courses. Here's an example of a patient with ductal dependent pulmonary blood flow. This patient has pulmonary atresia and duct entering into the pulmonary arteries in tetralogy of Fallot. This PDA is outlined here in red with demonstration of the LPA origin from the midst of the PDA and extension of that vessel to the right ventricular outflow tract and right pulmonary artery. A duct stent or PDA stent was placed here, providing longitudinal flow into the pulmonary arteries without the need for prostaglandin infusion. This patient's able then to be discharged for a interstage, followed by complete repair of the cardiac lesion several months down the road. Here's an example of a patient with tetralogy of Fallot and severe outflow tract obstruction who presents for transcatheter palliation. One can see the severe right ventricular outflow tract obstruction due to muscle bundles within the infundibular os and RV outflow tract. Here, a coronary stent is being placed from a femoral venous approach within those muscle bundles, crossing both the infundibular os and the pulmonary valve. And afterwards, angiography demonstrates unobstructed right ventricular outflow tract flow and improved saturations for the baby, who's now able to move on for an outpatient interstage, again, followed by later tetralogy of Fallot repair. Recanalization of occluded vessels is increasingly a part of our practice, especially in the inpatient world. These patients may present with chronic chylous effusions as a consequence of having lost normal lymphatic flow and central venous flow. And we're able to recanalize those vessels, sometimes placement of vascular stents afterwards, here showing a now normal left denominative vein and right SVC, which were not previously present. So I'm going to pass the microphone back to Jamie Bloch, who will review some of the indications for cardiac catheterization.
Thank you, Dr. Goldstein. Although we can't cover every single scenario that you may encounter in your patients in your practice in our presentation today, what we can do is describe some indications and different cohorts and theming for different patients that you may come across. In neonates, these patients can be referred to the cath lab if they have ductal dependency, such as critical aortic stenosis, critical pulmonary stenosis, or ductal dependent pulmonary blood flow being considered for palliation. Pre-op evaluation of patients with DTGA who have cyanosis. Also pre-op evaluations of hypoplastic left heart syndrome patients with intact or restrictive atrial septums. And also having patients come to the cath lab to help with their diagnosis if it's uncertain prior to the procedure. We can also address transcatheter neonatal palliation and also assist with vascular access, obtaining vascular access in those patients that are having difficulties. For pre-op evaluations, pre-op planning is helpful for the surgeons to determine their management in the operating room. Again, if the diagnosis is uncertain, coming to the cath lab is important to help ascertain that. Determining candidacy for surgery, such as screening for coronary disease in older patients, assessing pulmonary vascular resistance in those with pulmonary hypertension, their resting pulmonary vascular resistance, and also their response to vasodilator therapies, assessing shunt fractions, and also cardiac filling pressures. Are all very important information that the surgeons would like to know. Intervening on lesions outside of the surgeon's access or their physical field where they're working, the interventions in the cath lab are able to address those certain lesions. Single ventricle patients are referred to the cath lab for multiple reasons. Those who have undergone Norwood or hybrids for stage 1 palliations, they can be too blue, they can have arch obstructions, worsening TR or RV dysfunction that warrants further evaluation, and determining their candidacy to move on to stage 2 and also candidacy for transplant within a transplant evaluation. Those patients who have undergone Glenn palliations or hemifontaines for stage 2, they also can be too blue, or on the other spectrum, too pink. They can have persistent pleural effusions, arch obstructions, worsening AV valve regurgitation or ventricular dysfunction, assessing their candidacy to move on to the Fontan stage, or also their candidacy for transplant during a pre-transplant evaluation. For those who have undergone Fontan palliation, they can be too blue, including those who have fenestrations that may require closure of those fenestrations. To further evaluate Fontan morbidities and these things that are known that can occur in patients with this circulation, including stroke, protein-losing enteropathy, PLE, or also plastic bronchitis, and also thrombosis. If there's any pathway obstruction, it definitely warrants further evaluation for intervention to open up that circulation. Again, worsening AV valve regurgitation and ventricular dysfunction, and evaluating them for transplant during an evaluation, and also obtaining routine surveillance as the years go on. Post-operatively, patients can be referred to the cardiac cath lab to further evaluate residual cardiac lesions. It could be a diagnostic study to look at a residual VSD or any coronary concerns, such as after a Ross procedure. Or it can be interventional if patients have branch pulmonary artery obstruction, to come for balloon dilation or possibly stenting of those lesions. If patients aren't following their anticipated course and not progressing as you thought, they can come to the cath lab to be further evaluated. If diagnosis is uncertain, they may be referred. Also, if they have pericardial effusions post-op or persistent pleural effusions, if they have vascular obstruction or thrombosis, this can be addressed in the cath lab, and also to assess diaphragm function with fluoroscopy. Outpatients can be referred for cardiac catheterization for a multitude of reasons, some being for atrial septal defect or PFO closure, VSD closure, which is an uncommon reason, pulmonary or patent ductus arteriosus occlusion, aortic or pulmonic valve stenosis, branch pulmonary artery obstruction, or RV to PA conduit obstruction, coarctation. It can be a diagnostic study before surgery, before transplant, or to assess for pulmonary hypertension, and also doing post-transplant surveillance with biopsies or coronary angiography. Pre-procedural planning is definitely multifaceted. An important part is discussing with the family the indications for the cath, and also the goals of the procedure and what you want to accomplish with taking that patient to the cath lab. The risk of the procedure should be covered. Infection is an important one, though we use antibiotics before putting any devices or stents in. Arrhythmias, blood loss, clot formation. Heparin is used to prevent clots. Vascular injuries, more prevalent in our younger patients, younger infants and neonates. Nerve damage, hematoma, pseudoaneurysm, and of course cardiac arrest is one of the more severe risks. Informed consent is also an important part, and programs can address this in different ways. At times, consent will be obtained by the cath team alone, and other centers may have a more broader approach where the inpatient consulting team can obtain consent as well, with close communication with the cath team to know exactly the interventions that will be planned to be performed. Management of cath patients may be center specific. Regardless, excellent communication between the inpatient teams and cardiac cath lab teams is essential to ensure smooth transition with that patient into the cath lab, and also understanding of the plan of care during the procedure. Medication management should be addressed, especially with anticoagulation or antiplatelet therapies that would need to be held before the procedure. A bridge is sometimes necessary if those patients are off those medications to prevent clot, and that also has to be considered to stop those in a timely manner before the procedure. Vasoactive medications such as ACE inhibitors also are those that might need to be held. Pre-testing, chest x-ray, EKG, echo, all should be done and resulted, so the cath team has access to those studies. Advanced imaging with CT, MRI, or ultrasounds may also be required depending on the patient's situation. Lab work should be completed, and having an active type and cross for blood products is also essential for the procedure. Thinking ahead a little bit at post-procedural planning is also important to consider before the patients come to the cath lab. Their recovery, if it should be on the acute care floor or within the CICU, should be considered. And if they would require any sedation needs, which can be taken care of either CICU specific or on the floor if that would be appropriate. The duration of recovery, if new medications would be initiated pending the results of the cath, or any other specific changes depending on the patient's situation, should be thought about and planned for prior to the cath procedure. With interpretation and findings of the cath, it's important to review the primary data, looking at the angiography or the pictures and looking at the hemodynamic data. And you must interpret that data in light of the patient that you're taking care of. No one fits a certain box as far as what the data might show. And even though a patient looks a certain way on the floor to you, it might have very different look to them in the cath lab, and that data must be taken into consideration. It's important to communicate directly with the cardiac cath lab team to understand what they found, what was tested for, what wasn't found or tested. Just because something isn't listed on the cath report doesn't necessarily mean that you're clear and free of that. It just might mean that the cath physician didn't specifically look at that certain issue or question, and also what was intervened upon and what the cath physicians did during the procedure. Post-cath management is important to consider as far as flat time, which is all based on protocols in each program, sheath sites and sizes, use of any closure devices which might make flat time shorter. Patients may require sedation or further intubation after their procedure, such as in uncooperative patients who might have developmental delay or Down syndrome, may need further sedation to help with their flat time, or if somebody has significant pulmonary hypertension, intubation should take care of that too. Access sites, looking at those and assessing those after cath is important. Having a protocol to manage certain issues post-cath is ideal, so everybody understands that process. With pulse loss and rebleeding, those are examples of protocols that might be helpful. These protocols and education across the boards to all team members, including recovery area and floor nurses, are essential to excellent post-cath site care. Post-cath care is also intervention specific, depending on what the intervention was in the cath lab. Pharmacologic management might include new anticoagulation or resuming current anticoagulation. Our program here, we have a multidisciplinary approach to anticoagulation with a protocol reviewed and approved by our hematology department. And also, this is reviewed with primary cardiologists when they refer those patients to the cath lab to be sure that we are addressing the anticoagulation appropriately for each patient. Post-cath imaging might include obtaining echoes, chest x-rays, lung perfusion scans, such as for those patients who have branched pulmonary artery interventions, and occasionally advanced imaging with CT or MRI may be indicated. EKGs also can be obtained, especially if an intracardiac device is placed. Some common complications that come about after cath include pulse loss, especially in our younger patients. Other site-specific concerns, including rebleeding or oozing. The picture on the right shows a cath site with some oozing underneath the tegaderm dressing. Also, hematomas are something that can come up as well at the cath access site. Access site pain is common, which can be addressed with Tylenol or Motrin if needed. Chest pain or back pain also we can see, mostly in patients who might have a transcatheter valve placed or coarctation stented. They can complain about soreness and discomfort in their chest. And this is important to determine if this is to be expected after the intervention that was completed, or if it's more significant, such as aortic dissection, if it's sudden pain that expands through the back, or if it's more or less severe type of pain. This is a paper that is from Philadelphia in 2015, which instituted pulse loss management with a specific algorithm, which we have in our group here, have the protocol that we follow currently. And this shows that Lovenox is used soon after, or if we're concerned about any pulse loss. And with this protocol, we see that 94% of patients have restoration of pulse with the systematic process of addressing pulse loss. And this data is out of Cincinnati. Some less common complications of cardiac catheterization is vascular injury post-balloon angioplasty. It's important to determine if this is an urgent concern, which may require further intervention with a covered stent or possibly even surgical intervention, or if this is something that can be addressed with follow-up imaging. Pulmonary reperfusion injury. It can be anticipated for patients such as those coming in for multiple pulmonary artery balloon dilations, but this isn't always anticipated at the start of the case. Device embolization can happen. A brachial plexus stretch or injury can happen as arms are placed on the side of the head throughout the procedure. This can happen more with longer cases that need biplane imaging to make that angiography clearer. And typically, these injuries should go away on their own. Pulmonary hypertensive crisis can happen in those that have severe pulmonary hypertension. Stroke or neurologic injury is also very much a less common side effect that we see. Here's an example of reperfusion injury. This is a 7-day-old little boy who had diagnosed after birth with a left pulmonary artery thrombus. He came to the cath lab to have this addressed using angiojet thrombectomy and also serial balloon dilations of the left pulmonary artery. And you can see in the picture on the right that now there is flow to the left lung as well as the right lung. But because of this extra flow going into the left lung, we do see some reperfusion injury. This is a chest x-ray that was taken before cath that shows clear lungs for both right and left. And here, his x-ray after cath shows some haziness on that left side, consistent with reperfusion injury. With extended intubation and diuretic management, Over time, we see that his x-ray has cleared, and 5 days post-cath, his x-ray looks very similar to his baseline chest x-ray. In follow-up, a couple weeks after his procedure, he was had a normal exam and normal saturations, and he's doing very well. Here's an example of a device embolization. This is a picture of a PDA occluder device that was placed, and this is the ending images. On chest x-ray 4 hours after cath, we see that that device migrated there to the left lung. So this patient was taken back to the cath lab for device retrieval, and with catheter manipulation, the device ended up in the right lung, but it was successfully retrieved, and a second device was placed. This is an example of a vascular injury. This is a 7-year-old patient who had truncus arteriosus, who had RV to PA conduit replacement due to increasing symptoms. He was brought back to the cath lab for further evaluation and possible intervention. It was found that his conduit was stenotic, therefore balloon dilation was done, and as a result of that balloon dilation, there was a pseudoaneurysm after that angioplasty. Further reassessment by CTA the next day clearly showed the pseudoaneurysm after this dilation, which was stable from the cath images.
Thanks, Jamie. That was outstanding. So in summary, from our presentation this afternoon, cardiac catheterization is an important tool in the management of both congenital and acquired heart disease in pediatrics. Diagnostic and interventional roles for cardiac catheterization are many and vary widely between centers, providers, and patients. Understanding what happens in the lab really helps to improve both pre and post procedural care outside of the lab, and we hope this presentation gives a little bit of insight to providers who are typically not in the cath lab, a little preview as to what happens inside the lab. It's important to review the primary data whenever possible. And hopefully this presentation gives a little bit of a encyclopedia, if you will, a little bit of an understanding on how to interpret the primary data, but seek out the catheterization team and your institution in order to review these data primarily. Manage physiology and not terminology. For example, a PDA stent in an infant is most likened in its management to a BT shunt rather than a patient who underwent PDA device closure and goes home shortly after the procedure. Because a patient didn't undergo sternotomy doesn't mean that a patient doesn't have the same physiologic shifts that occurred in a patient who might have undergone sternotomy and cardiac surgery. And of course, high quality communication is fundamental to programmatic success. Direct communication between the cardiac catheterization lab team and other teams within the hospital setting, such as the inpatient acute care team, is really fundamental to growth and success with patients navigating through the catheterization laboratory, typically as but a small component of their inpatient stay. This is a picture of our group in Pittsburgh. Jamie and I want to thank you very much for joining the webinar this afternoon or the tape version thereafter. Our email addresses are up on the screen, and we'd be happy to hear from you with any questions or insights you'd be interested in sharing with us. So thank you very much for the opportunity today.
Dr. Goldstein, Jamie, thank you very, very much for an outstanding review and introduction to a complex topic. We look forward to many more sessions expanding on the foundation that you guys have provided today. I'll mention 2 things here. One, we will have a follow-up session continuing our theme of introduction to EKGs for the bedside provider. And this will be coming up on Monday, September 14th, and brought to you by Dr. Jackson and Angela Makita. I didn't know if there was time, Bryan or Jamie, there were a couple of questions. If you wanted to take a look at those. There was a question on fluid challenges, a question on calculating QP to QS in a univentricular heart. If you had a moment, that'd be great to hear your insight.
Sounds great. Thank you, Dr. Madsen. We appreciate it. I will review the questions briefly here. So thank you for us in a review. Fluid challenge during cath procedure, mainly diagnostic, are using standard volume formula based on body weight or BSA. Thank you. Most of the literature on fluid challenge and catheterization, whether it be to tease out restrictive and constrictive disease, or in the more recent world of fluid challenge in patients with congenital heart disease, such as with Fontan, typically utilize a volume that is weight-based. And so our routine is using 15 mLs of normal saline per kilogram of body weight. And we tend not to have a cap of that number. So patients may receive a liter or even a slight bit more if they're heavier. Next question, hopefully that answers that question. Thank you, Khalid. Talat asked a question, can cardiac catheterization for PPHN related to bronchopulmonary dysplasia with atrial shunts, can that be discussed? Sure. Historically, I think in general, we sort of shied away in the cath lab from cathing the early premature infants. More recently, we have evolved into cathing patients who are quite small preterm for two purposes. One is to get better insight into the degree of pulmonary vascular resistance abnormality and help tailor their pharmacologic therapy. So that's sort of the population discussed, and a little tangent from that population is the presence of atrial level shunt. And so in that population, it's really important to measure the VO2 in order to derive a very accurate FIC, cardiac output, and pulmonary blood flow, both for purposes of understanding impact of the ASD, but more importantly, to measure the pulmonary vascular resistance. Oftentimes the resistance is not profoundly elevated, but the ASD shunt is a real problem in that population. And there's increasing work recently of providers even using transcatheter devices to close ASDs when hemodynamically significant in patients with BPD or chronic lung disease. Of course, the other population that has become quite relevant to pediatric cath labs with chronic lung disease, bronchopulmonary dysplasia, have been those with not ASD as intracardiac shunt, but PDA as a persistent intracardiac shunt from being born preterm. And there's now work that's demonstrated satisfactory device closure via femoral venous only approach in patients down into the 600 gram range. So this can be done as early as several weeks of life in patients born as preterm as 23 weeks gestation age. So I think there's a lot of work in the last 5 or so years in that population that previously had really been delayed until they were older and larger and better candidates for catheterization. Miguel's asking about how do you calculate QPQS in stage 1 of a patient with a univentricular heart? So that is a little bit more of a targeted question. And I won't get into this here because it's hard without a whiteboard, for example, to illustrate this. But suffice it to say, with pulmonary venous saturations, a mixed venous saturation from the SVC, and an aortic saturation, which in a patient with a BT shunt would be the same, that aortic saturation would be the same saturation as the pulmonary artery saturation, then QPQS can be easily calculated and the resistance can be calculated too. We'd be happy to go through that offline, Miguel, if you're interested. And I think that rounds out the questions that I see on my Q&A screen. We'd be happy to take more questions offline or via email. But thank you again for the opportunity to share some time with you this afternoon.
Bryan, Jamie, thanks once again. Really outstanding. Look forward to more sessions just like this one. Everyone, I hope you are well, and we will see you on September 14th. Thanks very much.